My name is Suzanne Schindler, and I'm a neurologist and dementia specialist at Washington University in St. Louis, Missouri. I'm going to talk with you about the realities of treating Alzheimer's disease, a clinician's experience. These are my disclosures. So I have been a dementia specialist now for over a decade, and during that time, I have seen many of my patients unfortunately progressively decline due to Alzheimer's disease, develop increasing disability, and many of them have eventually passed away from Alzheimer's disease. So my role as a clinician has been to, when I first see my patients, to try to provide them with an accurate diagnosis, address any exacerbating issues like eliminating sedating medications, treating sleep and mood disorders, which are very common. I also recommend lifestyle modifications. They eat a healthy diet, get exercise, and have cognitive stimulation. I prescribe medications like acetylcholinesterase inhibitors or other medications as appropriate. And I provide a lot of caregiver support. I try to connect caregivers to resources that can help them, especially as patients decline and develop increasing disability. But despite our most well-intentioned efforts, our patients with Alzheimer's disease continue to decline. They eventually pass away, often from complications of Alzheimer's disease. So because this has really been rather grim, and we see on a very frequent basis how this affects our patients and their families, we've really been quite excited about the first FDA-approved treatments for Alzheimer's disease that modify a root cause of the disease and modify the disease trajectory. So these are amyloid targeting treatments. So they essentially activate the immune system to remove amyloid from the brain. Now we know these amyloid targeting treatments, or ATTs, do not cure Alzheimer's disease. They don't even stop progression, but they do slow progression of the disease. Over about an 18-month clinical trial period, it's slowed by about 30%. We're still learning about how it affects the disease longer term. I do think this is a meaningful difference for some of my patients, especially those that are really early in the disease course. And this is important. We think that these treatments have greater benefits and lower risks the earlier you give them in the disease course, and only patients with early symptoms are even eligible for these treatments. Now, there is an extensive process for identifying patients who have early symptomatic Alzheimer's disease who may benefit from ATTs. I'm not going to describe this today. This is described elsewhere. But we do work hard to identify these patients at our memory clinic. And all 16 clinicians at my center at Washington University are routinely ordering ATTs for patients who we think will benefit. And currently we have over 400 patients that are receiving ATTs. So what is the process of treating patients with ATTs? So it really is quite a big decision to decide to provide these to patients. As I mentioned, we go through a really comprehensive process to diagnose the patients accurately with early symptomatic Alzheimer's disease, have extensive discussions about risks and benefits, and when they finally decide that this is what they want and we think they're good candidates, we go through this process. So the first thing we do is we enter them in a registry. If they have Medicare, we enter them into the Medicare registry, which is pretty easy. It only takes maybe 10 or 15 minutes. If they don't have Medicare, we still need to enter them into a registry. The biggest registry is ALZNet, and This registry has a lot more information, and it's really meant to study real-world use of these treatments, so that's more involved, but certainly an option, and there are now many ALZnet sites that are registering patients. The next thing that we do is we submit an order set in our electronic health records. So this is basically we have to click on a bunch of boxes to decide exactly which treatment we want to provide, what sort of pre-treatment we want to provide, what to give if the patient has, for example, an infusion-related reaction. And then we kind of hand this over to some staff. The next step is to obtain insurance pre-authorization. This can be a bit complicated in the United States because we have many different private insurers and they may have different requirements. And this can take some time to get pre-authorization, and sometimes insurance do not, an insurance company may not pre-authorize treatment. And then we have to decide what to do in that case. And then after we get pre-authorization, we have to schedule infusions at a center near the patient that has availability. We're fortunate at Washington University in that we're part of a large healthcare system that has a network of infusion centers. So we can typically find a center that is relatively close to where the patient lives, where they can go get their infusions, but at times infusion capacity has been an issue. So we've had to schedule people for centers that are a little further away. At this point, we also schedule the monitoring MRIs. So for both ATTs, lecanemab and donanemab, there is a set schedule for monitoring MRIs, and we enter this at the beginning so that everything is set up. And this is to make sure that when someone needs their scan, that we're not scrambling to schedule things, because often the radiology centers schedule quite a ways out. So something that's important to understand about this process is there's a lot of administrative burden to all of this. And it's really been essential to have staff, especially to help with the insurance pre-authorization and the scheduling issues, because this can take a fair amount of time. And it's not something that really a physician will have the bandwidth to manage. So we've hired additional personnel just to help with these tasks. So now we schedule all of this. The patient is set up for their first infusion, and they get their first infusion. And we know that infusion-related reactions with both lecanemab and donanemab are really fairly common with a first infusion or two. Maybe a quarter to a third of patients may have some sort of infusion-related reaction. But then after that, we find they're relatively uncommon. So infusion-related reaction, what does that look like? We have a pretty low threshold for calling anything an infusion-related reaction. So it can be very mild. Often it's some kind of chills, headache, nausea, fever, just not feeling quite right. And in general, these are pretty mild and go away after the first few hours or day. We have found that pre-medicating patients with acetaminophen or antihistamine may reduce the likelihood of these reactions. So that makes a difference. And then patients do develop these symptoms, chills, headache, nausea, fever. We will treat them with Tylenol, and that seems to help. Some patients do have more significant infusion-related reactions like a rash. In those cases, we may treat them with steroids. There's a few percentage of patients that have significant enough reactions that we stop treatment. But again, that's just a few percent of patients. Most people do just fine. One note, and I'm going to be talking in a minute here more about amyloid-related imaging abnormalities, or ARIA. But these typically do not occur with the first infusion or two in the first month of treatment. So we found that a lot of patients have these infusion-related reactions with the first infusion or two. But when we have scanned them, because, for example, they had a headache, we've really never found that they've had ARIA. So in general now, when we see patients who are, for example, having a headache or symptoms consistent with an infusion reaction within a short period of their infusion, we don't do an urgent MRI to look for ARIA. Of course, you have to use clinical judgment here. If there's focal neurological signs, obviously we would scan them. So this plot is showing on the y-axis the patient number, and on the x-axis time. Each of these dots is an infusion of, in this case, lecanemab. So each row is one patient, so you can see that they're getting their infusions at a regular frequency every 2 weeks. And you can see our number of patients treated is increasing over time. The red is the first infusion. So I bring this up to show you where the A's are. This stands for ARIA. So we find most of the ARIA after the fourth dose during the first monitoring MRI. So that's where you see a lot of the A for ARIA. And we don't see much ARIA after that. Every once in a while, we'll see ARIA after 6 months, but it's pretty uncommon. Another thing that this highlights is that most people are continuing to get their infusions over time, every 2 weeks. We find that only about 10% of patients discontinue treatment. So most people do pretty well. We do see there is a fair amount of ARIA, maybe 1 in 5 patients early on, but then the rates are low. And in terms of what the ARIA looks like, this is showing in a case series of 194 patients that we recently published, what the characteristics are of ARIA, both in asymptomatic patients and symptomatic patients. And so we see that the vast majority of ARIA-H, shown on the y-axis, or ARIA-E, is isolated, meaning that it's only, for example, ARIA-H. What that looks like is often it's one little dot on a GRE or SWI sequence. This is still considered ARIA-H. Or it's isolated ARIA-E, which is often just a little T2 hyperintensity in a small area. That's the majority of ARIA that we see. Now, we do see some cases that are more severe. These are some examples of moderate ARIA-E or moderate ARIA-H here with some superficial siderosis. And there are occasional cases of severe ARIA-E or ARIA-H, but they're not as common. These are showing the individuals who develop symptoms of ARIA. All of these individuals had both ARIA-E and ARIA-H, both, so not isolated. And even with these symptomatic patients, they tended to have mild symptoms, shown here in green, which means that the symptoms did not interfere with their activities of daily life. We did have a couple cases of moderate clinical severity, so this did interfere with activities of daily life to some extent, but was not disabling. And we had 2 cases of clinically severe ARIA where we ended up hospitalizing the patients for monitoring. So in our paper, we detail the characteristics of patients who developed symptomatic ARIA. There were 11 cases out of 194. Again, most of them had mild symptoms, so something like a headache or confusion. And in most cases, these symptoms resolved within a few weeks or a couple months. We did have 2 patients, which was 1% of the patients at risk, who developed clinically severe ARIA, and we just hospitalized them for monitoring and steroids. One recovered fully after a couple months, and one has had mild residual effects. We did find one point that I think is important in considering whether you should treat a patient or not with ATTs, and that is we found symptomatic ARIA was much, much more common in patients with mild dementia, where they had significant impairment of their activities of daily living, as compared to patients with mild cognitive impairment. So it really is important that we try to start people on these ATTs as early in the clinical course as possible when they have mild symptoms, because the risks seem to increase as people develop more severe symptoms of dementia. So how do we decide whether we should stop treatment? Well, this is actually a bit complex, as I'll talk about. We think it's really important to make these decisions with the patient and caregivers, especially because in some cases it's really unclear what the best course of action is. We don't really have a lot of data yet to guide us in this. So again, we try to personalize our approach and make sure that everyone's in agreement. However, in general, if a patient progresses to a more significant stage of dementia, for example, moderate dementia, we stop treatment because we think at this point it's probably not helping them very much. But what if they're still in the mild dementia stage or MCI stage? What do we do then in terms of stopping after 18 months of lecanemab treatment? So one difference between lecanemab and donanemab is that lecanemab now has a maintenance treatment where you give it once a month. And so what we have chosen to do is to do an amyloid PET scan if we can. In some cases, insurance won't approve it or the patient doesn't really want to do it. But in general, we're trying to do an amyloid PET scan in 18 months. And if it's negative, we have a couple major options. So one is we can continue with the maintenance infusions as has been recommended, or if the patient prefers, we can just stop the infusion. Now, what happens if they're still positive? And we actually have had a number of patients who are still positive after 18 months of lecanemab infusions. So at this point, we would typically recommend that they either continue the full dose because they haven't fully cleared the amyloid yet, or if the patient prefers, we can stop infusions. Again, we're trying to personalize this decision. Now, in some patients, we don't do an amyloid PET scan at 18 months for whatever reason. At this point, we could consider continuing with the monthly maintenance infusions or stopping infusions. Now, in our clinic, we don't yet have any patients who've received 18 months of donanemab, but we have certainly been discussing what to do with regard to stopping treatment. So again, we're hoping to do amyloid PET scan in 18 months. And if it's negative, we plan to just stop the infusions. So with donanemab, there's not at this point a maintenance therapy. And the recommendation is just to stop when people are amyloid PET negative. However, we do expect that there will be some patients who are still positive after 18 months of treatment. So in those patients, we're considering continuing with the full dosing regimen and then rescanning at 2 months. If at that interval they're negative, then we would stop treatment. Again, all of this will have to be personalized. We are trying to increasingly get centiloid values in our patients to help us with these decisions. This has not been routine clinical practice with amyloid PET scans, but in this context, we think that having those numbers will help us, including with this decision about if and when to rescan them after 18 months. And then with donanemab, if an amyloid PET scan is not performed, we would probably just stop infusions. So this is complex, but these are the kinds of things that we're thinking about right now as we're treating patients with these ATTs. So overall, our experience providing ATTs to patients has been positive. We have found the support of clinicians by staff, and particularly advanced practice providers, have been essential to managing insurance issues, scheduling infusions, and monitoring scans, and enabling more clinic visits. I would not want to be doing all of this myself as a clinician. But this support has really enabled all 16 dementia specialist clinicians at Washington University to become comfortable with providing ATTs. And really, our focus now is on trying to initiate them as quickly as possible in appropriate patients. We think that patients and caregivers really appreciate having treatment options. And we're very clear that these treatments are not curative, but many of our patients still think they will benefit from them, and we agree and try to provide this as an option. And as we're going along here, we're continuing to develop new protocols, as I was describing, for treatment after 18 months. And we're hoping that there will be more evidence from real world practice that will help provide more of a basis for making some of these decisions and protocols. Overall, I would say that this first generation of disease-modifying treatments is giving hope to patients and caregivers and to us as well. We've certainly seen a lot of devastation from this illness, and we realize that we need even more effective treatments, but we're excited that we're at least getting started now with more effectively treating Alzheimer's disease. I'd like to acknowledge our clinic patients and their supportive families, especially the 11 patients and families who allowed us to detail their individual cases who had symptomatic ARIA. We are continuing to study patients in our clinic to develop evidence about how to best select patients and monitor them. And I've highlighted some of the people involved with those efforts. And I'd like to thank all of my colleagues at the Washington University Memory Diagnostic Center, especially our clinic director, Joy Snyder, and Madeline Pazinski, who has seen many of our patients who have been treated with ATTs. Thank you so much for your interest in learning more about treatment with ATTs.